Welcome to the Lived Experience Forum. This webinar event was created and developed on behalf of the Myalgic Encephalomyelitis or ME Group Australia to acknowledge ME Awareness Day in May 2025. The ME Group Australia would like to begin by acknowledging the traditional custodians of the land on which we meet today. I pay my respects to their elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. Just before I move forward, a little bit of housekeeping to remind the audience. This event is being recorded and it will be shared on our YouTube channel. Please turn off your video if you wish to remain private. Please keep your microphone on mute. We value the health and well-being of you and are serious about keeping our webinar welcoming and friendly. Please be respectful to each other in the chat. Please do not make defamatory comments about any organisation or person during the webinar. And please do not promote any unproven treatment in the chat. We are confident that you won't have a problem with this request. If we do notice you didn't respect our request, the background team will remove you from the session. And that's the crankiest I'm going to get today. So I'd like to begin by introducing the panelist group that we have today. First of all, Sandra. She has a background in IT, complementary therapies, and vocational training. Life was vital before ME developed in 2012 after a virus. An attempt to return to work faltered, social activities and hobbies fell away. With no education of PEM and appropriate pacing, her health worsened. It took 5 years to a clear diagnosis, then living within her energy envelope became her goal. She slowly stabilized but has remained in the moderate spectrum. Understanding the history of ME and following the biological science with preference for the ICC is very important to her. Sandra is passionate about learning from mistakes of the past and forging new care pathways. She is excited by MEGA's vision for a multidisciplinary clinic and supports the organisation as energy levels allow. And she holds the important role of director of MEGA. So welcome, Sandra. Next is Margie. Margie lived an active and healthy life until recent years. A registered nurse, Margie is passionate about her family and caring for others. She has battled 3 life-threatening illnesses: encephalitis, severe, is that idiopathic thrombocytopenia?
Yes.
Yes, and severe Legionnaire's disease, but considers living with ME her greatest challenge. Unlike her previous conditions, ME is poorly understood and lacks treatment, requiring Margie to research and educate others. Living with ME has required major adjustments. Margie is unable to work and has difficulty with most tasks. She is very grateful for her husband's significant support. Involvement in a support group has provided helpful information, connection, friendship, and a sense of purpose. Despite limited energy and the constant threat of PEM, Margie continues to advocate for ME awareness. So welcome, Margie. Howard is not here at the moment that we've seen, but if he does hopefully join us, he is a retired professional who contracted ME at the age of 55 in 2003. He spent the next 3 years in bed, looked after by his elderly mother. After many years, he was approved for the disability support pension, and then he transitioned to the age pension at 65, allowing him to travel overseas freely. With the return of his health, he embarked on a new chapter in his life. He spent 7 fulfilling years in Thailand, got married, and led a vibrant life running a creche in Chiang Mai. However, his health took a turn and he had to return to Australia in 2024. He rejoined the Bayside ME support group, and doing that was a turning point. It not only helped Howard, but also allowed him to help other sufferers by sharing his journey, providing a sense of reassurance and support. Howard's dedication to the cause led him to write reference material for the group and advocate for the establishment of a dedicated ME clinic in Melbourne, a crucial step towards better support and understanding for ME patients. Welcome, Howard, if you are here. And next we have Tracy. Tracy has lived with ME for 19 years, but was only diagnosed in 2022 and spent the next 2 years house and bedbound with severe ME. Over the past 9 months, Tracy has managed to find some treatments that have given her small but significant improvements in capacity. She now prioritizes spending time with her family, learning to paint with watercolor, and advocating for people living with ME, mainly via her blog, Not Just Tired, on Facebook. Prior to having severe ME, Tracy worked in leadership roles at TAFE, New South Wales, loved long walks in nature, yoga, tennis, netball, and swimming, as well as reading and weeding the garden. So welcome, Tracy. Thank you. Adrian, am I pronouncing that correct? Okay. No response is a good response.
Yes.
Yes.
Sorry.
Adrian comes from a family profoundly impacted by ME/CFS or ME, particularly on her maternal side. Severity ranges from relatives who are 100% bedbound, living in silence and darkness, unable to speak or eat unassisted, to those who can work but must strictly manage activity to avoid PEM. Our lives have been transformed by the research and guidance of the Workwell Foundation, whose science-based approach has helped us manage our illness and halt further decline. I'm honoured to be a part of this panel and especially grateful to Dr. Todd Davenport for his critical work. Welcome, Adrian, and thank you. And Melanie, if she's here, Melanie is an autistic counsellor, educator, and creative who has lived with mild to moderate ME since 2018. Though currently on leave from private practice, Melanie remains committed to advocating for a future where all therapists are equipped to support individuals with ME and related conditions. She is particularly interested in the impacts of PEN or PEM on mental health. Melanie is grateful to rest and pace on the Marlan Bara Yi Dingy country. I'm sorry, I've tried my best, in far north Queensland, where she enjoys picturesque views of the Bandar Jaruga Mergu from her window. Currently, mostly house and bedbound and a wheelchair user, she holds hope for a day when she can go hiking in the rainforest again. So welcome, Melanie. Okay. I just wanted to remind participants, if you are struggling to talk at any time, please just turn off your video so that I won't ask you a question. And if you prefer, you could type your answer in the chat and we'll read it out for you. And please let us know if there's anything else that would be useful for us to help you. Okay, as an icebreaker, I'm going to share a movie, a little 5-minute clip. I need to signpost for the audience, though, that the following video may distress some viewers. After the powerful 2016 campaign, Nothing Has Changed, some of the people in the video are no longer with us, including the young man who beautifully edited this video. I would like to especially acknowledge Anna. She has given us her blessing, despite her heartache, to play the video because she wants our voices to be heard. May is also a tough month for a mother with ME. She has also lost her brother, who edited the video professionally. I would also like to acknowledge and thank Millions Missing Australia for allowing us to share the video and for their ongoing support.
My life didn't go the way I thought it would go.
I'm always calculating how I spend my energy.
Our lifestyle revolves all around the illness.
It's meant the loss of my career, it's meant the loss of my vitality, it's meant the loss of friends, it's meant the loss of probably about 70% of my life, as I spend about 70% of my life in bed.
It's kind of meant that you see the world going by and you're not part of it.
I'm always budgeting. I'm always doubtful about if I do a certain activity, what's the payback going to be.
Think of rest as being like medicine for us. So we have to take our medicine, and for me it means 70% of my time is taking that medicine in order that I can actually be in this chair today.
And we all know that we're going to probably spend tomorrow regretting every minute that we've stood out here in the rain and be laying in bed.
The majority of ME people who are stuck at home, stuck in bed, they can't go to the bathroom by themselves. They can't, it takes so much energy for them just to lift their hand to their face.
The severe can't leave their beds. The severe need 24-hour care. The severe need tube feeding. The severe can't even look at a screen. The severe can't talk. So that's why we're being the voice for those patients.
I think it would be wonderful if people could get a diagnosis and get a diagnosis early and get treatment early.
I want funding to go towards diagnostic testing. I want funding to go towards figuring out the mechanisms behind this.
We've been ignored for years and years and years, and we're just sick of that. And we're hoping that people will start to look after us.
Getting the awareness out there is critical. It's very powerful for these young people, majority of young women and many of them mothers, saying this is what's happened to me and you need to listen to me, and I'm very sick.
The next step right now is sitting up and watching TV for more than 10 minutes. That's the next, to have some friends around again and to start just having those little bits of normal life that people just take for granted. That's all we hope for, it's just the next little bit, and we'll go from there.
It's not as altruistic as it looks. I just want my life back. I don't want this disease anymore. I don't want it to affect 70% of my life. I want to go back to work. I want to see my friends. I want to parent my children properly. And I want to be a proper partner to my husband. And that's what I'm fighting for. Today we are in Melbourne on the steps of Parliament House. And what an amazing sight for sore eyes you all are. That's what I can say. Haven't we created an uprising from our beds? Yeah. We should physical strength, we certainly make up for in will and determination, and clearly we will need that today in this lovely Melbourne weather. Thank you, Melbourne. Today is our day to use our most precious resource, ourselves, to join voices in one united message to our government. See us! We are the millions missing. Hear us! We need your help. This is our time. So let's raise our voices above this rain and let the government hear from the millions missing. Thank you. Thank you, everybody. It's been amazing. It is amazing. Thank you. It's just from the exertion of speaking, my speech, it affects my speech.
Before I introduce our keynote speaker, Dr. Davenport, I just wanted to quickly and briefly define post-exertional neuroimmune exhaustion, or PEN. So everyone knows what we're talking about. It's the focus or the topic of our forum today. So it is the characteristic feature of ME. Essentially, it's the inability to produce sufficient energy on demand. It's a form of fatigue experienced in response to minimal effort, with often a delayed onset and a prolonged recovery time. PEN also exacerbates a spectrum of other symptoms, including sleep disturbances, pain, sensory sensitivities, nausea, confusion, and the list is exhaustively long. PEN is consistently reported as the most debilitating symptom of ME that impacts a person's health and well-being. Now, I'd like to share with you a little bit about Dr. Todd Davenport, who's kindly donated his time and would love to contribute to the forum today. Thank you very much. He is a tenured professor and chair of the Doctor of Physical Therapy program at the University of the Pacific. A graduate from University of Southern California with further advanced qualifications and training from the University of California, Berkeley campus and the University of Portsmouth. He leads teams across physical therapy, public health, and complex chronic illnesses like ME, with an interest in PEN or PEM and preventative health care. His work continues to drive innovation in clinical education, interprofessional collaboration, and advocacy. In addition to research, Dr. Davenport serves as an editorial lead across Cardiopulmonary Physical Therapy, Orthopaedics and Sports, and Pacific Health journals. He is also very active in community health and youth programs. So, welcome, Dr. Davenport. Would you like us to call you that moving forward, or how would you like to be referred to?
Thank you. That's a very generous introduction. Call me Todd. It is after hours. There is no need for the titles.
Okay.
I'm just pleased to be here to help contribute. Thank you.
Mm-hmm. No, thank you. Okay, so the panelists on the forum today tried to come up with some questions that they would appreciate you responding to, Todd. And Tracy is going to ask the first one.
Thanks, Nicole. Welcome, Todd. It's great to have you joining us today. Thank you.
Thank you for
So
having me.
the first question that we came up with was, given that most people with ME are too unwell to undergo the 2-day CPET, how would you measure PEN in these people?
I mean, what a great question, Tracy. Thank you. Probably one of the things that my group and I, the Workwell Foundation, involving Stacy Stevens and Dr. Mark Van Ness and Dr. Chris Snell, who are exercise physiologists, Jared Stevens as well, exercise physiologist. We're known for the cardiopulmonary exercise test, but I'm also a physio by training. And so as a physio, I have the opportunity to work with people with ME across basically the entire spectrum of disability, from mild to very mild to very severe. And as you point out, there are people, plenty of people with ME who are too unwell to do a 2-day cardiopulmonary exercise test. And so as a clinician, the first thing I do is listen to people. And it sounds simple, but it really is as simple as that. So part of the research that we've done over the years with the Workwell Foundation is sorting out some of the physiology of how the body behaves during exercise in the post-exertional state. But the other thing that we've done is we've really tried to understand the symptom signs and symptoms involved in the recovery response. And one of our most recent publications suggested that even just reporting one unusual sign or symptom a week after a known exertion is sufficient to be able to direct you to the fact that a person may be experiencing post-exertional neuroimmune exhaustion. Because really the symptom experience looks quite different, and I don't have to tell anyone with lived experience on this call, obviously. But you have all kinds of unusual things, and so and fatigue doesn't really describe it. It's soul crushing, it's bone crushing, it's can't move your limbs. It's the feeling of nothing left to be able to move. But it's associated with a whole host of additional signs and symptoms that are unusual. Brain fog, which is kind of a cute way to describe cognitive dysfunction. Orthostatic intolerance, dizziness, palpitations, immune reactivation. All of these things we don't see as part of the recovery response after an exercise task in someone who just is a little out of shape. So totally different. Now, so what we've tried to do is use some of the science to legitimize what people are telling us, because oftentimes it's these subjective reports that get dismissed as being too outlandish and too or maybe embellished. But we have some good science suggesting that these are reliable ways to differentiate a normal versus a very abnormal recovery response following a known exertion. And there are some other ways that we could look at this as well. We have some good questionnaire survey data now. The FunCap, for example, is one emerging way to track disability associated with PENE. We also have a post-exertional malaise / post-exertional symptom exacerbation activity questionnaire we mercifully abbreviate as the PAC, which is another survey that is condition specific that can be used, that's very short. And then there's some promising objective markers like hand grip, heart rate variability, and different things that may not be necessarily specific to PENE, but certainly can help us capture that disability experience.
Thank you. Thanks, Todd. Nicole.
Thank you. Adrian?
I think that Todd's comprehensive answer to the question that he's just answered really addresses what I've said. So I think we can move on to the next question, which is Margie's one.
Okay, will do. Okay, Margie.
Hi, Todd. Thank you for your time. We really appreciate it.
Thanks, Margie.
Thank you. People with ME often describe sore muscles as a symptom of PEM. Is that how I say it? We're used to PEM. In the case where sore muscles in PEM follow only mental or emotional exertion with no physical exertion, so the sore muscles follow an emotional event or a mental exertion, do you consider the sore muscles to be a result of lactic acid or something else?
Wow, what a great question. And you point out something really important, Margie, which I think a lot of people who don't live with the disease don't really understand, which is that there are different types of exertion that can create PEM or PENE. So as a physio, as an exercise physiologist, I talk a lot about exercise and physical exertion, but we can't sleep on mental and emotional exertion as well. And as you point out, the symptom experience of PEM or PENA can involve some pretty unusual symptoms and signs. Like, for example, I just mentioned, physical exertion can cause cognitive dysfunction. We don't expect that normally. And, cognitive exertion can cause these physical symptoms of muscles burning and so forth. In that case, I'm not sure if it's lactic acid. I can't rule it out because one of the things that we know about exertion is it tends to be accumulative. And what I mean by that is that, if you exert physically, then it lowers your ability to exert cognitively. If you've exerted cognitively, it lowers your ability to exert physically. So it's possible that a lowered threshold for physical exertion could still generate some lactate that can cause burning. But I really think that the muscles burning is more a factor of neuroinflammation. And we know that neuroinflammation from some of the metabolomics data, which are metabolomics is a series is a really complex biochemical studies involving kind of chasing molecules and bits of molecules around different body fluids. And we know that the molecules and bits of molecules that are associated with an inflammation in the cerebral spinal fluid that bathes the spinal cord and the brain, is higher in people who are living with ME. So I really think that the muscles burning sensation could be a factor of lactate, sure, and we do have some data suggesting that lactates are elevated, particularly after a bad day, in a person who's experiencing an exacerbation. But I think a lot of it has to do with neuroinflammation.
Thank you for your answer. That's fascinating. The next question we have for you. First, I'll preface and say thank you so much for your work and WorkWell Foundation. When I discovered WorkWell Foundation was when I stopped pushing and crashing and started to monitor my heart rate. So thank you so much. It saved me from getting worse. Literally saved me. So the question. Thank you. The question is, can you please comment on the benefit of people with ME using wearable devices to monitor heart rate variability, and oxygen saturation in order to aid pacing?
Yeah, thank you for that, and I'm so glad that worked for you. As your question suggests, I'm a huge proponent actually of using objective markers to guide pacing, and here's why. People get concerned. The concern that I think lay people have, or clinicians who don't understand the disease have, is that all of this sort of laying around makes people lazy. And what they don't really understand is really people with ME are really at substantial risk of overexerting, not underexerting. People tend to do more when they feel better. And so rather than kind of thinking about all this laying around, making people lazy and out of shape and needing to exercise, what we found is that actually the body has a dysfunctional way in which it uses oxygen to break down fats and sugars. We call that aerobic metabolism. And since the aerobic metabolism is not working properly, the body does not respond normally to exercise. And what's more is avoiding use of that dysfunctional aerobic energy system seems to be associated in many people with an improvement in their symptoms and even a progressive improvement in their baseline. Now, we refer to that as pacing, and pacing has been defined as this intentional act of balancing activity with rest, and in people who are in an exacerbation, a lot more rest than activity. Now, it's not curative, so I won't make that claim, but it does help with quality of life, and it does help a lot of people with, and it does add to the benefit of additional interventions. If you're working on other things and have other interventions that you're trying, ignoring your pacing is a good way to doom some of those interventions to not work. So getting back to your initial question, Margie, of what's the benefit of using a wearable device? Well, the wearable device allows something else to do the checking for you. You don't have to worry about sort of checking in with yourself. You have something that can remind you when you're overexerting or when you're crossing over into that threshold of using an energy system that just doesn't work for you. And so that's the major benefit. Now, heart rate variability is information that is derived from heart rate, and it says something a little bit different. So heart rate gives you sort of a moment-to-moment marker of how hard your body is working. It's a little bit like sticking your head out the window and seeing if it's raining, and predicting the weather that way. Heart rate variability gives you a little bit longer term view, or sort of intermediate term view of what your nervous system is doing. So it's a little bit like looking at the 10-day forecast to see if it's going to rain next Wednesday. So you have a little bit more predictive value from heart rate variability. Now, in some talks that I've done, including one that Dr. Mark Van Ness and I did for the Norwegian ME Association that's up on YouTube, we talk a little bit about the interplay between using heart rate and heart rate variability to help make decisions about your exertion. Oxygen saturation is an excellent way to look at pacing, particularly if you have lung disease and impaired gas exchange in your lungs, and that impairment gets worse with exertion. We don't frequently see that in people with pre-COVID ME, but with people with post-COVID ME, we do see that as being a problem. So oxygen saturation can be a very important marker for some people as well. But I really appreciate that question, Margie, and hopefully I didn't overkill in answering it.
I was just wanting to see, Todd, if I could jump in, and this is unscheduled, but as a follow-up, because this just reminded me of this topic. I recently noticed I use Apple, an Apple Watch and an Apple phone, and there's a MET score, which talks about physical activity, and I find that really interesting. So I'm interested in your take on what that is and what it's measuring, because my scores sitting in bed indicate that I'm actually walking around outside doing something quite active, and obviously I'm not.
It's really interesting, right? So So METs are, and thank you for the question, Tracy. METs are metabolic equivalents. It is an estimate of how hard your body is working. And there are certain metabolic equivalents go back to the amount of oxygen that your body is consuming, which is a direct measure of its metabolic output and therefore how hard it's working. And the metabolic equivalent is basically normalizing your estimated volume of oxygen consumed to that we would measure with you resting. And so anything above 1 would be a factor above, kind of working above rest. So what the Apple Watch is doing is it's estimating how hard your body is working based on your heart rate. And so if your heart rate is elevated, there's a proprietary formula built into the app that tries to then map your heart rate onto a volume of oxygen. And from that volume of oxygen, then dividing that by the average resting volume of oxygen consumed will give you a MET score. So the reason your METs don't make sense is your body's working harder at rest than the average person. So the only real reliable way to measure METs is through an exercise test or through directly measuring your oxygen intake, which we can do with a portable unit with you even laying in bed. So you wouldn't even need to use an exercise test. And working that math out for yourself. So it's, that algorithm's probably pretty close for people who are up and around, pretty fit, healthy people. But for people with ME, it's going to way overshoot and make it look like you're weeding the garden when you're in bed.
Thank you. That makes sense. And it also ties in, I'm sorry, I don't want to take this over, but my step count is always wrong also. And so what I ended up thinking was that rather than counting it as a step count, I'm actually using it as a reflection of how much work my body's doing today compared to what it did another day, rather than saying it's wrong because it's talking about steps that I haven't actually taken. And I found that useful.
Yeah, that totally makes sense. And the hard part is that, of course, all of these algorithms and formulas are proprietary, so you can't see what they are. When we talk about measuring heart rate variability, it's the same thing. They somehow take this complex measure and distill it down to a number, all in a proprietary way. So anytime you're working with apps, it's always good to try a few to see how they work, few devices, see how they work, because some will be a little easier for people to interpret, maybe a little more accurate for them than others. So in a research sense, we are constantly using research grade equipment that gives us all of the raw data that we will then do the math. But most people are not going to be in a position to do that or want to do that. So,
Todd, thank you. If I can just go back to the oxygen saturation just for a quick question. So are you saying that if we use an oximeter, that our blood oxygen levels will have some kind of reflection? I'm thinking about our cerebral blood flow, and that I understand that there's been studies that have shown that people with ME have poor cerebral blood perfusion. So how do those two things marry with information?
No, it's a good question. So in our experience during exercise tests, we don't usually see blood oxygen content reduce, which we would call desaturation. So we don't see people desaturate during exercise. Some of David Systrom's work using invasive cardiopulmonary exercise testing, which is done in a cardiac catheterization lab where they measure oxygen content in the arterial and venous blood, has shown that actually there is more oxygen content returning to the heart than we would normally expect per unit workload. And it's because of this observation that we think that the body is not extracting the oxygen, but that the oxygen is present to be extracted.
Yeah.
And so we would call that impaired peripheral oxygen extraction. Now, how that relates with cerebral blood flow, it doesn't really relate well, because the impaired cerebral blood flow tends to be more positional, and it tends to be more related to impairment in the autonomic nervous system, your fight, flight, or freeze nervous system, which is in charge of sort of reducing the diameter of your vessels as you sit up and stand up. That response is impaired in people with ME, and as a result, there's less blood going to people's brains. And so it seems as though that response is a little bit less. The oxygen content in the blood going to your brains seems normal, but there's just less blood going there.
Right. Thank you.
You're welcome.
From Adrian.
Hi, thanks for coming, Todd. It's amazing to actually meet you and see you in person.
Thank you for inviting me.
Oh, we're just delighted. I guess I've seen the impact of your approach on my family, and particularly I'd like your insight into the impact that your work had on two close relatives of mine. One relative was profoundly affected and was lying in the dark, still unable to move, eating pureed food, and against all medical advice, said, "No, I'm not moving." She spent over 18 months just trying to lie still, like trying not to roll over in bed, despite the extreme pain. And slowly, over those 18 months, her impairments reduced. And although those gains appear very, very small to an outsider, after 18 months, she's able to roll over in bed, starting to tolerate dim light, starting to eat non-pureed food, which had an profound improvement on her quality of life. Another relative took the same approach, was much more capable, but stayed in bed almost entirely for 4 months, during which time his symptoms abated or reduced a lot. But then what he found was that he was trying to stay in bed, and then he'd find he just would end up in the bathroom without planning to be there, without meaning to be there. So it seemed as if once his body naturally began it did more as it became capable of doing more, even though intention was to do less. And I guess for both people, the success came from not trying to push their limits and from doing the exact opposite of the medical advice that they were being given. And I'm just wondering that, given the traditional rehabilitation focus, which is to encourage a gradual increase in activity and encourages people to push the envelope, I'm wondering how you suggest that clinicians and patients reconcile this, the pacing approach and the heart rate-based pacing approach, and with a counterintuitive. The traditional approach of rehabilitation, I guess I'm saying, sorry, I've got a bit lost here, brain fogged. So it seems like, patients know, and we are dealing with knowing that we need to rest more, but the medical establishment is telling us to do more. And I'm just wondering, do you think that the medical community is beginning to shift its approach? And how do you think we could maybe talk more effectively to the medical community?
Well, I really appreciate the question, and thank you for those anecdotes. That's really it's really meaningful to know that that your family and you have really have benefited. I really appreciate that. Um, yeah, so as a physio, my colleagues don't know what to do with me. So we're we're the exercise people in the healthcare system, and here I'm telling people to do less, that less is more. More is not more, less is more. We recently published a section on myalgic encephalomyelitis in the American College of Sports Medicine's guidelines to exercise testing and prescription, which is sort of at the risk of sounding sacrilegious, kind of the Bible of exercise, professionals. We all, especially in the U.S. and the U.K., it's sort of like the reference book, And it's the first time that there's been a section on ME in that book, and of course in that book we argue against exercise. So we're probably the only chapter in the exercise Bible arguing against exercise. So we've really committed to the bit here, and I think rightfully so. Now, the question being, do we think the medical community is beginning to shift? And I think so, slowly. The UK NICE guidelines in 2021 de-emphasized the role of graded exercise for the first time. We got kind of caught up in the Cochrane review. There's a Cochrane review that was put out in 2019. It was due for an update related to graded exercise in ME, and the Cochrane Collaborative decided not to do anything with it, even though I was part of a group that was looking into updating it, updating the protocol, and potentially updating the content. The ACSM book now has a section on ME. So people who prescribe exercise as part of their living, do exercise testing, have a resource. So I feel like the word is getting out in the more foundational texts. I think there's many groups who are doing great work in clinical translational work, like the Bateman Horn Center has clinical guidelines. They're based in Utah here in the U.S. With the U.S. MECFS Clinicians Coalition. Some of the long COVID clinics are coming up with some good guidelines for people with post-COVID ME who are living sort of under the umbrella of long COVID. And so I would say, yeah, but with the caveat that the shift is slow, and always way too slow for the people who are living with this disease. So it's always a privilege to be able to speak with groups like yourself who are doing the hard advocacy work to sort of change practice where you are in Australia. And so that's something that I can always get behind.
Thank you. I had a second question, and it just relates to orthostatic intolerance. I'm just sort of wondering if it could be used as functional marker. In my personal experience, the severity of my orthostatic intolerance, if I measure it by a modified lean test, I do it just from lying to sitting, and it seems to fluctuate in parallel with my overall level of physical impairment. So like on days when I'm more impaired, my orthostatic intolerance is noticeably worse. And then when I'm doing relatively better, I'm better rested, the test results will improve as well. So I'm just wondering if you think that the severity of orthostatic intolerance could be used as a proxy for clinical marker for overall physical functional capacity in people with ME/CFS.
I think this is a great observation, and thank you for that. Probably could spend the next 2 hours just sort of talking about just this question, and I will do my best not to do that. But this goes back to a little bit of how I addressed Margie's question, talking a little bit about the autonomic nervous system dysfunction associated with ME. And we see this autonomic nervous system dysfunction even on exercise tests, where the heart rates during exercise are blunted. So we see a rise in heart rate, but it's not nice and linear associated with an increasing workload like we normally would see. It tends to sort of rise and then that rise tails off. And we refer to this as chronotropic incompetence or chronotropic intolerance. And that's indicative of autonomic dysfunction. That's the fight, flight, or freeze response is not working sufficiently enough to increase your heart rate during exercise. We also see it, as you point out in your question, when we do positional testing, and we see impaired orthostatic responses in terms of heart rate responses to just standing or changing positions. This is where I get in a little trouble with my friends in the POTS community, postural orthostatic tachycardia syndrome. But there are some people with orthostatic intolerance who have PEM, and that orthostatic intolerance is part of their PEM. But not everybody with orthostatic intolerance has PEM. And so a big issue in sort of the POTS community is if you don't have PEM, you can exercise. But if you do have PEM, you should pace. And that's a very controversial idea in POTS right now. So I get myself in a little bit of trouble, but I'm talking with a lot of people in the POTS world about this balance. And we just published a case study of a young lady with POTS who also had post-exertional malaise. And so we described how we balanced the need for pacing early on rather than just sort of starting all in with a graded exercise approach, which was making her worse. So there's a big conversation to be had here. And I would say that correlation between orthostatic test results and disease severity, there's a lot to that. And I think we should probably chase that up with formal studies in ME for sure. I really appreciate you bringing that up.
Well, thank you, Todd. Thanks for your comprehensive answer.
Thank you. Now, before you go officially, I wanted to just quickly check the chat that's been going off.
Yeah, there's some
to
questions
see
in the chat, Nicole.
Yeah, would you able to speak to them, Danielle?
Yeah, sure. Erica asked, can you please ask Todd to post some examples of his research that you recommend that we read for further information?
Yes. In fact, as the panel moves on, I can go ahead and spend a little time highlighting some selected articles. There's one in particular that might be useful to take to physios and exercise physiologists if you're working with them. That kind of provides our rehab approach. I can do a couple of other articles as well. Yeah. So thank you, Erica. I will be putting those in the chat.
Okay, thanks, Todd. And also from Erica, what is the acronym for the PAC survey that you mentioned, Todd?
Yeah, it's the PAQ, and I'll post that article too, so that we can take a look at that. We're working right now on a Spanish translation, which I don't know is helpful in Australia, but certainly here in California we could use it. So,
Anna asked, is there a wearable that measures HR, HRV, and O2 sat?
I believe there is, and of course, I can't think of it off the top of my head, but I will try and locate it and link to it in the chat.
Thanks. Robin's asked if there's any particular wearable devices that you recommend.
I generally will recommend the Polar brand. So I have two parts of my brain. One part's a research brain, one part's a clinician brain. My research brain says get clean data. My clinician brain says do what people will actually do because you live in the real world. And so those parts of my brain are in conflict. But the polar verity sense is an armband, which is useful. It's useful because it's a little bit more proximal than a wristwatch. Sometimes the wristwatches don't measure quite as accurately as something a little more proximal. The gold standard, of course, is a chest strap, Polar H10. People hate the chest strap. It's uncomfortable. It's sweaty in the summers. It's not ideal. So the armband is a nice compromise.
Awesome, thank you. We also got a clarifying question from before. So does POTS plus PEM equal ME?
Yeah, I think anything plus PEM equals ME to me. So there is some controversy about this, of course. So I get myself in trouble when I say long COVID plus PEM equals ME with some people because they identify more with a long COVID label than PEM, and I'm not here to tell people what they should and shouldn't identify with. But anything plus PEM to me as a researcher is ME.
Awesome. And they just said thank you for the straight answer. And that's all the questions from the chat, but Robin has her hand up.
I wanted to ask a question. Are there any medical people in Australia doing the kind of work that you're talking about? I'm extremely reticent to see exercise physiologists because of the fact that they usually just recommend exercise.
Yeah, there are some folks who specialize in complex chronic disease. And again, I probably need to go back into my email inbox because I've talked with a few people from Australia who seem really sharp with this, who I would be comfortable recommending. And Australia obviously is a big place, and my geography is terrible because I'm from the U.S. and and anything outside of California is hard for me. But I would be happy with potentially putting a couple of names of a couple of people in the chat just to get people off to a good start.
That would be amazing, and thank you for this. This has been really clear, helpful information, and yeah, it's been great. Thank you very much.
I'm glad, Robin. Thank you.
I'm just wondering if I could ask a question. Our lead GP organisation has just recently sent a letter to our lead medical research body, the NHMRC. The NHMRC are looking at reviewing the ME guidelines. In their letter, they referred to the complexities of diagnosing ME/CFS, and they use the terminology that ME is a medically unexplained syndrome, sort of going back to when the UK was using that. I'm really wondering if there are any definitive guidelines that we can use and say, hey, this is not medically unexplained. There are physical and biomedical abnormalities. We know that the people that have written this document are aware of the research and are aware of these medical abnormalities. I'm just wondering, sorry.
Yeah, no, thank you for the question. And I think I responded to a call. They did a scoping survey of asking for items they should look into in this review, and I remember responding to that call. Obviously, it's incorrect to say that ME is a medically unexplained syndrome. Obviously, we don't have all of the details nailed down in terms of the etiology, but it is really hard to it's hard to defend, I think, any position that this is a medically unexplained syndrome. The guidelines that I like to go back to are the NICE guidelines from the UK. They're not perfect, but they're I think they're better than most. And getting to know those and socializing those, I think in Australia might be a good place to start.
I I think our problem, Todd, is deeper than that, because I'm pretty sure that the authors of this advice from the GPs, they actually are aware of the NICE guidelines. And in fact, we had a group of Australians argue in conjunction with the UK authors, argue against the NICE guidelines.
Yeah, it's hard. So getting folks on board with kind of a contemporary understanding of ME is always kind of dicey work. It kind of depends on who's in charge of these organizations, and sort of the ideas that they have. Yeah, I mean, I certainly would be interested in some additional dialogue about this, because kind of offline, because this is an interest of mine. Now, here in the US, we're so decentralized with our medical system that it kind of looks like we have it together, but we really don't. So this is why I kind of default to the UK NICE guidelines as being a good place to start, because they come from a solid evidence review, and they really are used to help dictate policy within an organized health system. So
thank you for those thoughts, Todd. Margie, I noticed a while ago you had a question.
Oh, thank you. I was going to leave it given time, but it's a really quick, more a comment to Todd. Thank you, Nicole. When you mentioned the polar armband, and yes, if you could possibly please put the details in the chat, I'd appreciate it. But I think a lot of us are using the Visible app for symptom monitoring and objective monitoring as well, with the Fingo reader. We're waiting for that. We can't get the Visible armband in Australia. So I guess I'm not really asking you a question. I'm just saying, perhaps we get the polar armband now, because how long would the Visible app be? And I know you're not involved with Visible, I don't believe. Is that right?
I had some conversations with them very early on about their algorithms and so forth. So, but I mean, what Harry Leeming and his team have done since those conversations has been fantastic. So I went ahead and dropped that in the chat. But the Verity Sense actually is what Visible uses.
So could you say that again, please?
The Verity Sense armband is it's the same thing that Visible uses.
Thank you so much. That's useful.
Of course. No, I recommended because at first Harry was looking at I think as a result of his patient panels and some beta testing, trying to do some using the wristwatch, but the wristwatches were really too inaccurate, I think, to do the kinds of work that Visible's doing. So I'm hopeful that the armband has been well tolerated by people. It sounds like it's done well.
Yeah, thank you.
Thank you.
Robin, do you have a question now?
Yes, it was on the Visible. That was the one that looked very interesting to me, because it's also got the app that you can rate other symptoms. I'm waiting for it to come to Australia, but wondering about your views on it. I mean, I'm very reticent on data collection and stuff, and also that it's a private company. I was thinking it would be wonderful if one of the ME groups could devise something like this, so the funds go back into ME research. Do you know anything about the Visible people?
Yeah, I've had the good fortune to speak with a lot of them. And so I do know that obviously there are concerns about privacy and such. And I think those are reasonable just in the modern world. My sense of the company is that they're doing everything they can to ensure privacy. But I would encourage you to ask those questions of the company themselves in order to be as comfortable with how they're using your data as possible. I also know that they're trying to give back to the community to in the manner of hosting research studies on their platform and so forth. So there's that going on as well. So so yeah, I would encourage you to ask those questions and see if you can get yourself to a point of being comfortable with that. And if not, there are other options out there, including kind of the old-fashioned way that we used to do, which is using journaling and kind of writing down heart rates and so forth. So, and a lot of that guidance is still on the WorkWell website.
Thank you. That's really reassuring, particularly as the full app is quite expensive as an ongoing.
Mm-hmm.
Thank you.
Okay. In the interest of time, I was wondering if we could maybe move on to the next part of the forum. And on behalf of everyone here today, thank you so much for your time and contribution, Todd. And perhaps if we get through the next section and if you're still here, we can ask you more, but up to you, as I appreciate. What time is it where you are?
It's 11 o'clock, but it's Friday night. We're just getting warmed up here. So
okay.
I'll go off camera and do my homework. So
Okay,
I think I had some things to respond to in the chat, and I'll sort of listen as we go, because every time I hear lived experience, hear from lived experience, I learn a lot. So I really appreciate that. And thank you again for having me if I don't have a chance to speak with the group again. Really appreciate you all.
Thank you. Thank you.
Thank you so much.
Next sort of part of the forum today is to allow the 6 panelists that I've introduced earlier to sort of have a conversation around some discussion points, of which there are several. So I'll open it up to the general floor, but if anyone doesn't start speaking, I might name some names. But would anyone from the panel like to respond to what are the most impactful aspects of PEN-A?
I'm happy to start.
Oh, excellent. Way to go, Melanie.
Awesome. I'm going to take a mental health and emotional perspective, because that's the kind of work I do. So in both my personal and professional capacity, there's anecdotal evidence that during and following PEN-A, some people experience distressing thoughts, self-talk and emotions, including things like irritability, hopelessness, shame, and anxiety. And I just want to say, if you've had that experience, that's a really valid response to the experience of PEN-A. Yeah, that's all I'm going to say at this point, but curious if anyone else can relate to that.
Yeah, absolutely. We talked in another forum a few times of how we have all become, these people in the discussion, really much more emotionally labile, reactive, irritable. And the irony for me is that I'm aware that I'm far more triggered more easily. I'm aware of that, but the irony is that then if I don't halt that kind of emotional response to perhaps the normal life, then I end up in more PEN-A. And so, I'm very fortunate to have a very supportive husband who's calm and patient. And I use his face as a measure for me that if, and this is just new since ME, it was never before, if I'm starting to go off rails a bit emotionally, I see his face, he won't say anything. And I know that to protect myself from further PEM, I need to really pull back, walk away, or whatever it is. So yeah, definitely agree. It's a part of PEM.
Margie, do you have any strategies that work for you that might be helpful for others to stop yourself, like from spiraling
Yeah,
any further?
I think the thing is recognizing in yourself, whether you've got ME or whether you're a regular healthy person, it's really difficult to recognize it, but that's the goal, I think, to feel your body changing as you're becoming emotional. The deep breathing that we all find so valuable, but particularly people with dysregulated autonomic nervous system, just the effect of a few slow, deep breaths. Looking elsewhere is another thing that I find really useful. I just look somewhere, and it's a little bit like that sort of panic attack thing. What are 5 things that you can see? If I look somewhere else, it takes me away from that current thing. That's about
Thank
it.
you. Yeah, they are good. They are good strategies. Is there anyone else that wanted to comment on that, Howard?
Yeah, I'd like to make a few comments. This is a life journey. What's happened is that when you've got ME, your whole life's turned upside down. So it's a process of accepting yourself and accepting where you're at. It's a really difficult thing. And these comments that people are making is you're having to get in touch with your feelings and who you are and reevaluate your life and your relationships, everything. So it becomes very challenging. And I think I think it's overlooked that just what sort of impact ME has on your life, I know for me, I've had fortunate because I've had many tools, and those tools I did a lot of psychotherapy for 3 or 4 years. So that was the first point for me to get in touch with my feelings and understand myself more. And then the next tool I've got is meditation and stillness and grounding, all those things which are essential to help, I think. I'm trying to think then there are many tools, but don't underestimate the challenges that you're facing here, to move forward and to just be still and to be aware of, who you are and be worldly. It's a challenge, Yeah, and
Thank you, Howard.
if you're not prepared to grow and face that, it's hard to go forward. And many people really struggle.
Yeah. Yeah.
Thank you.
That's okay. And it sounds like getting stuck in an emotive sense is not going to be helpful for you at all. And Howard, you just mentioned several strategies or tools that you've shared with others. So thank you.
Yeah, thank you.
Yeah. And I can see that Sandra would like to contribute.
Hello, everybody. I'm so sorry, but my computer's just decided to have a penne attack and crash. So I'm just on my phone while my computer's trying to reboot. So I don't even know whether you can see me or not. I hope so.
We can.
I missed the beginning of the answers there, but I just came in on that emotional ability bit, which Margie was talking about, which is really interesting. I saw somebody write about that recently, and they actually described it really well because it's so hard to explain just how severe it can be and how extreme. I know, like, I've been out and about with a friend, and I've said, I have to go now, I have to go, and they've stopped. They wouldn't go. They were chatting with the shop attendant or something until the point where I've lost it and go, I really have to go now. And like, sound crazy and feel crazy. And that person described it as like drowning, and it's like you're flaying. You're just trying to save yourself, and you do come across outrageous and maybe screaming and all sorts of things you wouldn't normally do and that you're quite ashamed of. But it's out of control. It really is out of control. You're in a spot then where your autonomic nervous system's fried, and you really are sink or swim. So just please, anybody who doesn't understand this so well, do realise that if somebody's telling you they need to relax or they need to go, they really mean it. Anyway, I was just going to, my input for this question of impactful aspects of PEN A. The biggest one that's bothering me in my life at the moment is restriction. I have moderate ME, and I've gone from the quite moderate to severe spectrum to right to probably middle moderate. And it just means that I have to live such a small life. It's so boring for a person who's very vital and wants to be out and about and used to be very social. I love dancing and all sorts of activity and nature. To manage PEN A, I have, as Todd referred to earlier, about pacing and your energy window. I've actually spent many years finding it, but I have managed to learn to live in my energy window, and that requires me being at home 90% of the time. I don't know whether I can talk about LDN so much. That's helped my quality of life, but still hasn't changed that pacing. I still have to do that. And many other things and supplements that I do to bolster my energy. The pacing is just absolutely necessary. And using mobility devices and things like that, just to be able to have a quality of life. But the restriction is the biggest thing. I have to give up so much just to keep that stability. I'm happy, though, in that stability, stabilizing. I have been able to improve my baseline somewhat and enjoy what I do have more, have less symptoms, less severity. But, you know, it's a really hard thing to do. Anyway, thank you. Thanks, Nicole.
That sounds like for you that having to be in control and schedule your time and energy is the most frustrating part about it for you. Not much spontaneity.
Yeah, that's right. You really have to say no to a lot of things, and it breaks your heart.
That's unfair.
Even the excitement, you know, like before this event, I was so excited, and I could feel myself during the day dropping because the excitement was taking my energy.
Yeah.
Quite cruel.
Similar to what Margie was saying and Melanie about having to control your emotions and not feel them as you would have usually liked to have done.
Yeah.
You have to sort of squash and distract yourself and live a very controlled way.
And that also impacts what you can give other people. So you might not be able to support friends that are going through a hard time as much, or share their excitement with things as much.
Yep.
Yeah.
Well, the way that you do help others is by contributing to things like this today. So, and contributing that way. So yes, you may not always be able to help others when you would like to, but rest assured you're doing it now.
Thank you, darling. I'm going to try and get over to my big computer again. So
okay. All right.
Thank you.
Oh, yep. Tracy, would you like to
Sorry,
say
I'll be brief. Because I'm not sure that we've touched on it, but for me, the most impactful aspect is the consequence of going back to my dark, quiet room after clawing my way out, and the unpredictable nature of that. So how long will I be stuck in that room again? How unwell will I get? How long will it last for? And will I actually get back to where I was before? All of that is unknown every single time you have PEN A. And I use an analogy. It's a little bit like snakes and ladders. I work really hard by doing all the right things, pacing, etc., to climb up the ladder to get that little bit better. And then, I might have a doctor's appointment or something unpredictable happens and I slide back down the snake. And I don't know which ladder I'm going to find to get back up again. So for me, it's largely that unpredictability, and once your unpredictability of when it's going to happen, and also then once it's happened, what's going to happen from there? Am I going to recover? Thanks.
So that almost sounds like the opposite of living a controlled life. Despite doing that, you still don't know, and there's no guarantee if you do everything right.
I think it's that. I think it's there's no guarantees, because sometimes you can do everything right and still something will go wrong. Your body's just not coping. And even just only recently, I realized that, I know this is probably obvious to everybody, but we talk about physical exertion, but that includes things like if we have an acute illness or an accident or, an injury or something that I'd never really associated with exertion. But your body is trying to deal with something. So there's so many factors involved in exertion, I think, that it's hard to control all of those things, even as hard as we try.
Yeah. Margie, would you like to comment?
Just a quick comment, but the irony is when we talk about emotions, it's not just difficult emotions that can set us into PEM and deteriorate it. It can be happy emotions. And, we have, someone said earlier, we have such a small life because we're constantly trying to pace, and then if we do go and do something, it's difficult to manage all the stimulus, etc. And then when you have the, occasional or rare opportunity for some pleasure and some joy, that can trigger a PEM episode.
That seems very unfair. So you're damned if you do and you're damned if you don't. Sorry if language was offensive for anyone, by the way. That's the first question.
Could I just add something there?
Sure.
I've just thought of another tool or strategy that I had. Was I used to go shopping, and of course, getting overwhelmed with sensation if you go to a grocery shop or a supermarket or whatever. So I bought a camping van, and that was my go-to place. As soon as I got exhausted, it didn't matter where I was then. I was closer to some sort of safety, some recluse.
Wow.
Yeah.
Thank you, Howard. So you went to a safe place that you knew worked for you.
That's right.
Yeah. Thank you. All right, let's move on to the next.
Sorry. I was just going to quickly say I've done the same as Howard. I drive a van. I've got a bed in it. I've got a little Uri bag. So basically, I can stop and rest and lie in the back of the van at any time. If I need to go to the toilet, I don't have to go and find one. I can use the Uri bag. I found it life-changing.
Yeah, that's right. Life-changing.
Yeah. Thank you, Adrienne. Moving over to the next question, it's pretty similar. I'll ask it, but if everyone feels that it's sort of already been answered, maybe we'll move on to the next one. What are the most inconvenient, unexpected, and unknown triggers of PEN? I think we've talked about positive and negative emotions, but was there anything else you wanted to say, Margie?
One of the things that can be very problematic is the weather, changes in weather.
Right.
I have a dear friend who's very, very affected by the barometric pressure drop. And it doesn't affect me in the slightest, but for her, it's major, puts her in bed with migraines and bad PEM. And I'm sort of going, oh, has the weather changed? But she can feel it. So it's completely not something that you can control.
Yeah.
She just has to experience it.
But she's your barometer.
She is indeed. She's educated me in all
Look
sorts
at that.
of things.
Yeah, she's a valuable asset.
Yes. It's very sad though.
Okay, not to make light of it then. My
Sure.
apologies.
Sure.
Does anyone else can relate to that or have any other? Melanie? Yep.
I'm not quite sure if this was mentioned expressly, but I guess problematic triggers being, say for example, my partner comes home from work and wants to tell me about their day. If there's distressing content in that, sometimes we have to delay conversations because I am not cognitively ready or emotionally prepared, or you get triggered into PEM during an important conversation. Yeah, I find that as difficult. And the other person, I can imagine it's hard not to get a sense of rejection when I then forget to come back to that conversation topic, even though I said I would. But yeah, brain fog.
Yeah, I think that's why it is. I've heard people describe that it's easier to associate with people within the ME community because everyone understands where you're coming from, whereas people that perhaps aren't, or like your partner, who I'm assuming does not experience ME, you'd have to constantly be explaining yourself. Margie or anyone else want to share any more thoughts regarding that question, or we'll move on to the next one? Oh.
Sorry, I don't know how to put the hand up. I'm so sorry. But look, I find it's the chemicals because you can control your activity, you can kind of deal with your emotions as well as you can. But if somebody arrives to see you and they've covered in perfume, there's not much you can do about it. Even if they go and wash it off, it doesn't go. It's still on their clothes, it's still in their hair. And it can trigger. I've been made sort of speechless by sitting next to somebody with perfume. And the perfume ladies, I call them.
Did you say something, or what? How do you deal with that situation?
If it's in my own home, I will say something. But this could be out in a shop, in a restaurant. That's when you can't really do anything about it. And I don't know if other people find this, but I find I can smell it at first and I go, oh my gosh, that's awful. And then I don't actually sense it anymore. But about half an hour later, I will have a big crash and I'll be brain fogged and have to sleep.
Yeah. Margie?
The multitasking is something that is just so challenging because, it's just part of how we manage life in our society, that we're talking to somebody and we're doing a task and we're thinking about something else. But for me and many that I know of with ME, it really has to be just one thing at a time. My example is if I'm well enough to wash the dishes, I cannot cope if somebody talks to me. So really, I'm doing three things. I'm standing, so I've got orthostatic challenges. I'm washing the dishes, so I'm thinking about process. And if somebody talks to me, I will straight away start to feel dizzy, my head will bulge, and I'll be sweaty. Take the talking away, and I can manage. So it's all these times when we think nothing of just talking to somebody while we're doing a task. But that example has really helped me look at all the activities that I do and am I doing, I think it's in a later question that we'll talk about it more, but am I doing as little as I can in that moment, rather than doing multitasking, just try and do one thing, one sensory, one audio, etc.
I think I understand it in terms of different sensory inputs all coming in at once. That's, can be overwhelming. And I believe it's sort of different types of attention. So that's kind of, is it divided or alternating? It's hard to switch from washing your dishes to then being able to let in someone sort of talking to you at the same time. So the threshold is not is low to be able to cope with that.
Yeah, and I think that's the case for sure. I mean, it's also, my GP explained it to me in terms of a brain injury, which also something I'd love to touch on later. But that many of our ME symptoms are similar to a brain injury. I had encephalitis, so I've experienced a brain injury, and they're very similar. But with as my GP, my neurologist explained it to me, the brain, our brains don't take a straight path in the most efficient way to decide what to think, what to do. They're inefficient, and so their brains take, wandering pathways through the neurons, transmitters, and consequently it's really hard to concentrate, and I think that compounds it when it's multitasking.
Yeah. If no one else wants to comment on this question, I might move on to the next one. Describe the signs of PEN you would like clinicians to understand and make adjustments for. So what would you find helpful for medical doctors, allied health, anyone to know?
I'm happy to. You go first.
Sorry. I guess my worst experience with it was actually visiting a specialist who was very, very au fait with ME/CFS. However, I was so brain fogged by the time, like driving there, getting there, and even though I lay down at the appointment initially, when I sat up, when he asked a question, my brain was processing the question. I didn't have time to actually get an answer before he kind of decided that my answer was no. He'd say, have you got the symptom? I was still processing it, my answer, and then he'd move on to the next question. And that was actually dealing with somebody very, very cognizant about ME. So I think they need to know that we actually need space, we need time. And by the end of the appointment, we haven't got a clue what happened in the last half, what was said, what was told, we were told. So we kind of need notes or a task sheet about how to move forward. That's my experience.
And what about being provided questions in advance, so you have had time to formulate the answers before even showing up for the appointment?
Absolutely. To be able to just write it down, because I think we present as intelligent with it people, and when we first arrive, and so they think that they're dealing with, and we are intelligent with it people, but we lose that through the appointment. So by the end, for me, I'm just this this sort of thing of jello that's kind of hearing words and wondering what on earth is being said, and smiling and leaving going, oh, okay.
Yeah. Thank you, Adrienne. Melanie, you've got a question? Oh, sorry, not a question. You'd like to contribute. My apologies.
Yeah. No, that's okay. As someone who is autistic as well and struggles with communication, if I lose the ability to speak, whether that's triggered because I'm autistic or whether it's a PEN symptom, I would like clinicians to be more open to alternative ways of communicating, whether that's I hand you my page of written notes at the start and you read them instead of asking me the questions that I've answered clearly in my notes. And look, when clinicians do that well, it makes a huge difference to what I get out of the appointment. And yeah, how productive it is. And also being willing to, if I need to type on my phone and have it read out what I want to say. There's lots of different apps for things like that. So yeah, loss of speech or difficulties with speech.
And I've noticed just with GP consults that I've been to lately myself, they are asking me for consent to record. So if we could be provided with the recording of the consultation to then go over again later would potentially be helpful. Oh, so many people want to speak. Okay, I think Robin, you were next off the...
Yes, one of the things that really affects me is when they fire questions, a number of questions in a row. My brain just I'm just struggling to get the answer to the first question, and then the next question comes in and I just can't. I can barely communicate.
Yeah.
And it often happens. Sometimes the doctors just assume things, and I don't have the energy to say, oh, hold on a second, that's not right, because they're on to a different
topic or different question.
A different part of the different topic or part of the conversation.
Yeah.
That really, sorry, I've got a dog in the background whining. That really, I just can't. But the sensory things, the light, sound, and chemicals are all things that could easily be accommodated for, and that would really help.
Yeah.
Thank you.
Thank you, Robin. Margie, did you want to go next?
My GP, talking about the signs of PEN and coping with that, my GP has actually helped me together. We looked at my symptoms in PEM and what we could do about any of them, not so much preventing, but supporting them. And she's sort of come up with the idea that I liken to an asthma plan, that this is the medications that I take when I'm healthy, and then this is what I do when I'm in PEM. And so she's actually prescribed for, I don't need it in regular life, but if I've got an asthma exacerbation in PEM, then I take a montelukast, which is a mast cell stabilizer. She's also recommended that I increase my antihistamines when I'm in PEM. And so by the way, I take twice the daily dose of antihistamines normally, and I go up to 4 times the daily dose of antihistamines, which is the limit. And also she's recommended that I take anti-diarrhea medication because that's IBS flare is one of my PEM symptoms. So it's just, it really helped enormously because I've got a system, I know what to reach for. It's great.
Okay. Thanks for sharing that, Margie. What about Sandra?
Hi, ladies. Got my computer back. It's much better. You've actually taken quite a few things off my list there, so thank you. But 2 that weren't was doctors can watch for signs if they understand what PEN might look like, or when you're starting to fade or you're going into the doorway of it. I know I used to get the death pallor like nothing else. My face goes like I'm dead. And I always wear lipstick because it makes me feel like I'm more alive. But when I go to an appointment where a doctor doesn't know me, I don't wear it. So they can see what's happening there a bit, I hope. They can see your eyes really dull out. They can watch for these things and hopefully make accommodations. They can see that you're having word finding problems. They can assist you and try and help you find the words and not put them in your mouth, which is unfortunately what happens sometimes. I've got a really great GP. She's known me since just before I became ill with ME, so we work really well together most of the time. But recently this year, I've had a whole host of other appointments with all sorts of different people, and it's been really, really difficult trying to get your story across. One of them wrote a report, which was very important. It was a respiratory sleep clinic, and I got a copy of the report, and I said about a third of it was wrong. So I was at home, I'm scratching through it, I'm changing it. I went back to the review appointment just recently, and I said, could you please update this? I don't want all this wrong stuff on my record. Mm-hmm. So, what everyone said before, that happens. They're not listening to you. They're not letting you process. Yeah. They're putting words in your mouth. Yeah. And it would be really wonderful if they could understand that we have that slower processing speed. Like they're running with an old IBM, 34.
Yeah. A dial-up modem.
Yeah, that's it. Yeah. But we're still there. We're still smart. We've still got something to say. Yeah. Thank you.
Thank you, Sandra. We might move on to the next question, if that's okay. Along the similar topic of clinicians and what you would like them to know, would anyone like to speak to the preparations they personally have to make to attend an appointment? The version of yourself that you tend to present to clinicians, and can you please describe the aftermath that they don't typically see?
I might have a go at this one. Oh, sorry, Margie, you've got your hand up. I haven't found the hand up button. Sorry. Thanks. I just wanted to mention in this one that a big part of my preparation is figuring out how to bring up topics without getting my doctor offside. I spend a lot of my cognitive effort doing my own research, figuring stuff out, listening to podcasts, reading research, not just Googling. And on top of that, so I shouldn't have to do that in the first place, but on top of that, I then have to work out what's going to be the best way to approach this with this particular doctor so that they won't just think I'm Googling.
Sounds like you have to be a mind reader.
Did tell me that early on. And recently I had a successful appointment with an immunologist about MCAS. But I also had another problem show up in my blood tests, and she said, oh, it's probably nothing. We've all heard that, haven't we? And I said, well, can we just do a little bit more looking into this, because I'd done some reading. And I said, I really want to find out if this is something that we can do something about, because any improvement that we can find makes a big difference to my life. Yeah. And she then wrote that in the report back to my GP, which I was really grateful for, because that to me meant that particular specialist really understood that I'm not here looking for letters and numbers after my name. I'm actually looking for things that can be treated and ways to improve my life. And so in terms of the preparations more broadly, we have to do so much to get there. We have to rest for so much longer before we even get there. We have to write lists, and like Melanie said, we have to write up all our notes so that we can make sure we cover everything, because we'll probably forget it all when we get there. But for me, the biggest thing is if we could have a collaborative approach to our appointments where we were respected as partners in our treatment, then that would take a whole heap of pressure off me trying to figure out how to phrase and approach a conversation with my doctors. Thanks.
It sounds like that you are having to advocate for yourself to be taken seriously, and you are walking on eggshells, hoping you don't mention something that's, as you said, putting them offside, which sounds extraordinarily stressful before you even have the appointment. And Margie, would you like to comment now?
This was a really interesting question for me because I think we all sort of go to the doctors trying to do our best. We really want them to understand we're authentic, and that we can really be heard. But I was reflecting on my parents' relationship with their doctors. As a child, I was dressed up in my Sunday best before we went to the doctors. They polished shoes and all of that. They spoke to the doctors as if they had some kind of superpower. And I just really wonder if that cultural expectation is actually still there a little bit. I don't think doctors are superpowers. I'm a registered nurse, so, I know a lot about doctors, and they're just humans like anybody else. And sadly for the ME community, the majority of them are letting us down. But I still find myself, no matter how I feel, if I'm well enough to get to the clinic, I stand tall, I hold my head up high, I use a bright voice, and I think that's so that I will be taken seriously. And yet I'm giving the doctor the wrong impression. And I'm going to think about this a lot more because it's not helping my cause at all. And if I can just speak to the aftermath while I'm here.
Please do.
Yeah, so the aftermath, it's just for me and probably everybody else, it's a huge exacerbation of symptoms. I generally have a longer appointment because I prefer that rather than multiple short appointments, because the exertion of getting there and all that sort of thing. So I can feel myself kind of slipping away after about 20 minutes. I'm starting sweating, my brain is bulging, I'm dizzy. I'm starting to trouble with word finding. When I go to stand up, my legs are heavy and weak. My heart rate is through the moon. I need to be driven, so I get driven home, and then I spend hours in bed and then a few days of PEM. And that's all to go to a medical practitioner to try and help my condition.
Yeah. I can recap a few things that we've spoke that allowing additional time to formulate a response, have the option of either providing your notes ahead of the appointment so the doctor can then become familiar, so you don't have to waste your precious energy with you, accommodating any sensory sensitivities in terms of light, noise, sound, that type of thing. And interestingly, the fact that we want to present our best selves to clinicians, I think also kind of speaks to society's values and expectations that we've internalized when we are having interactions with someone that perhaps we think is of authority, rather than, someone that, as Tracy said, we can collaboratively together design our treatments, whatever works best for us, rather sort of than having a power differential. And both Sandra and Tracy want to speak. So would Sandra, you go first? I think you had your hand up first.
Thank you. I wanted to add into that, because that's absolutely massive what everyone's just said. I just had an experience the other week where I had trouble breathing, and I was out and about, and I just ran into the nearest medical centre, and I said, I'm having trouble breathing. And the way they treated me, I know it's an urgent thing, and they're going to look after you wherever you go. At first, the receptionist did say, can you go to A&E? And I said, I can't. I've got myalgic encephalomyelitis, and I could not cope with 6 hours in the waiting, that I'd end up worse. And they decided they'd get the nurse and bring me in. And the way they treated me was astonishing. Come in, respect, look, check, give you an ECG. Doctor came in, checked all over. Although he did the rapid fire question thing, asked me things. Like I must have repeated it myself 3 times, which was ridiculous, having trouble breathing and having ME, and they're doing that to you. But still, I had respect. And it shocked me because I don't see that if I go in and say, I've got a breathing thing going on at the moment. It's not, and I also have ME, and I'd like to know the links. The minute you say that, they seem to get a bit strange because they don't know the links. Even if I give them information, they're not prepared to look at the links or diss me. So I think I dress up when I go in because I want to be respected.
I know.
And it really got me thinking about that now.
Interesting thought. Yeah.
The other thing, just quickly too, I sort of speaks to the last question as well as this one, but orthostatic intolerance really needs to be educated on and understood. It's a huge part of what makes it so difficult for us. When I had my initial appointment with our wonderful and renowned Dr. Donahoe, his wife has a yoga studio adjoining his surgery, and the receptionist could see that I was fading and I was needing to put my feet up on a chair. Offered me a reclining position on all the props in the yoga studio. And Dr. Donahoe came in with his dog, and we conducted several-hour interview consultation on the floor. Now that's extreme, but I mean they can offer you a bench.
Lying down is mandatory. Yeah, the minute I get there and say hello to you guys, I've got to lie down because I've already been up for way too long, just getting ready and getting across town. I'm already way into PEM.
Thank you, Fiona.
Sorry, I got confused. That's all right. That'll do. Thank you.
Tracy, did you want to add anything?
Yeah, I'll try to be quick, Nicole. I just wanted to contrast my experience at the doctors when I was early on in my disease and didn't know as much, and would just turn up, as Margie's spoken about, and I would take 2 weeks to recover from a doctor's appointment every time. When I asked if I could lie down, it was like, oh, what do you want to do that for? One cardiologist even refused to let me lie down after I'd done the stand test, which was horrendous, and then diagnosed me with anxiety. But anyway, I'm not upset about that at all. But what I wanted to say is that now I know myself much better, and I have a whole heap of tools in my toolkit. So I now have a reclining leg raising wheelchair. I have a hat that's got this duck bill thing over my face so that no light gets in. I wear these horrible glasses. I take anti-inflammatories before I go. I wear earplugs. I rest in the car when we get there before I get into the wheelchair, and then I rest again in the car after the appointment. And now I recover in maybe 2 days. But also the doctors and their support people actually treat me much differently. Now that my invisible illness has become visible. And I think that's terrible, but also it means that my experience of attending the doctors with all that paraphernalia around me has led to people seemingly to understand how sick I am. So win-win, but it shouldn't have to be that way, because I was sicker when I was treated poorly. Even though I'm very sick now, I was much sicker then, and I was dismissed, and that made me even sicker.
Yep. So that's just a classic case of judgment by the way people are looking. Yep. And behaving. Yep. Margie, did you want to say one last thing?
Mindful of the time, and I really want to say this before we finish. For those people who are not well enough to leave their home, we really need to keep pushing for Medicare covered telehealth appointments that do not need a periodic in-person appointment. They've stretched it out to 2 years in some situations, but it's incomprehensible that we have people in our country who are stuck at home, bedbound, and they cannot speak to a doctor on the phone because of our prohibitive restrictions.
Yep. As we've only got a couple of minutes, I will say thank you to the formal part of the forum this afternoon. There were a few more questions we could use as prompts if anyone would like to stay behind for a bit longer. I wanted to leave you with this thought. Considering PEN and the potential long-term consequences, would you participate in research if an opportunity came to you? And also, if you could, please have a think about making a donation to the ME Group Australia, which is currently run by volunteers to help enable future forums and webinars like this to get bigger and better and keep producing this work to help get our voices to be heard. And also the long-term goal is to get more clinics up and running to allow for safe, collaborative healthcare service delivery to be formulated for you, by you, for you. So on that thought, I will say goodbye.